Jo, doorzetten we ze.
I am Frederick Julie, the president of the Oeso Foundation. And before we get started, I will just give you a few information about this meeting that will be hosted by Dr. Ji He and Dr. Yusheng Mao from China. We'll introduce the panel a little later. Currently, we have about 80 participants who registered from 13 countries. What I will ask you is to leave your cameras on for better interaction, but to keep your microphone muted unless you're asked to unmute yourself. So to unmute and mute, you have a button on the bottom left side of your screen. Then you have the camera on/off video. If you want to raise your hand to ask a question, you just have to click on the participant button here, and you'll have a small button saying raise the hand. Then I will see this and hand the microphone to you as soon as it is possible. You can ask your question or raise your comment through the chat or just by raising your hands, and we'll do the interaction this way. Thank you all, and now I will hand it over to Robert Julie. Robert is the founder and deputy executive director of Oeso and the director of the executive committee of the Oeso Foundation. Robert?
Merci Frédéric. I will begin it in French first to express a great welcome to Mrs. Anne Bruant-Bisson, qui m'entend peut-être si elle est connectée, pour lui souhaiter la bienvenue. Madame Bruant-Bisson est la chef du service de santé de l'ambassade de Chine, de France en Chine, et elle a bien voulu donc répondre à mon invitation de venir assister à cette démonstration un petit peu de la coopération qui existe actuellement entre l'Oeso et nos différents collègues en Chine. Just wanted, Mr. Jeho, if you are here, to say a great welcome to Mrs. Anne Briand, who is the head of the health department in the embassy from France to China, and she is now connected and will watch a part of this section. Well, I would like to tell you briefly that in this difficult situation, time of lockdown in various countries in the world, this fourth edition of the clinical case discussion promises to be an event, and for several reasons. Indeed, it will afford the international scientific community an exceptional exchange, which is of interest to us all, and continues to provoke numerous uncertainties, controversies over therapies on cancers of the esophagus. And these controversies will be stimulated by the different opinions expressed by the members of a very, very prestigious panel. This panel includes members coming from many countries, from the USA, in the person of Andrew Chang, who is surgeon and researcher known for his work on cancer of the esophagus. Another member comes from Africa, from Bomet, Kenya, with the team of Russell White, known by everyone in the world, and he is the chairman of the COSEXA that brings together 118 institutions from 27 countries in East, Central, and Southern Africa. This panel also involves members from Europe, Professor Townsend Goetze, who will contribute the vast experience in the field of esophageal cancer, that of Salaheddin Albatran in Frankfurt. Also coming from Europe, Professor Stefan Mönig. He's the director of the first pilot center in esophagology created by the Oeso Senpai platform. And he will be also joined today by Stéphane Bonnet, who will contribute from Paris, hopefully, his ideas, as well as those from the Institut Mutualiste Montsouris with Brice Gaillet. But there is another reason why these discussions will be a landmark. This session, which is impressive, outstanding panel, demonstrates the dynamic contribution of China to the Oeso Stanford Senpai platform. This cooperation is put forward today by the presence of Professor Jie Ho, President of the China National Cancer Center and President of the Chinese Academy of Medical Sciences, and together with the presence of Professor Yusheng Mao, also from the Beijing Cancer Hospital, accompanied by members of their team. Professor Jie Ho and Yusheng Mao are the founders of the first Oeso Pilot Center of Excellence in China, but even more, and this is why these discussions will mark an important date in our cooperation, even more so because on this occasion, Professor Jie Ho and Mao will present 5 new Chinese Oeso pilot centers of excellence in esophagology, shown on this map all over China, in Shanghai with Professor Heisheng Li, slide, Professor Heisheng Li, in Chengdu with Professor Yongtao Han, in Fuzhou with Professor Chun Chen, in Shenyang with Professor Shen Chu, and in Shenzhen, Professor Zhentao Yu. And they will be all most welcome in this platform with all of us. This discussion will be led by Professor Yusheng Mao. It will also involve several of their collaborators, as well as other participants coming from Guangzhou, coming from Zhejiang, from Wuhan, and from Chengdu. They are all shown on this slide. And they are on hand now to take part in the discussion that will begin now. But before, I would like to express the recognition of Oeso and of the Oeso Senpai platform to Professor Jie Ho and his whole team, who last year in November, just 1 year ago, hosted the 15th Oeso World Conference in Beijing with 130 sessions, more slide than 4,200 participants. This on-the-spot event, la suivante, afforded irrepressible opportunity for direct contact that resulted in far-reaching projects completely in line with those proposed to the scientific community by George Triadafilopoulos, that you can see to the left on this slide here, and the advisory board of the platform, which he presides over. In the days to come, you will have the occasion, I think, to see the very latest educational project unveiled, which will be the gastroenterology portal. Can you show this, Frederick? It is built on all the accomplishments of Oeso and prepares the road ahead in the years to come. You will find out more very shortly on the Oeso website. And now I am pleased to hand over with us from Beijing to Professor Jie Ho. Professor Jie Ho, I am proud to say, a friend of his. Thank you. Professor Jie Ho may say the word.
Oh, hello.
Well, glad to see you. And I said at the beginning that I wanted to welcome here the representative of the Department for Health and Social Affairs at the Embassy from France in Beijing. And Mrs. Anne Briand is probably connected today, and she will watch to a part of this session.
Okay. Okay. Let's start now. Beginning.
Yes.
Everyone here?
Yes, we can hear you. Thank you.
Okay. Everyone here? Okay.
We can start.
我先说两个。 distinguished professors, experts from foreign countries, and dear Chinese colleagues, and welcome to participate in the fourth International Cloud Forum on the Multimodality Treatment for esophageal cancer, and hosted by Beijing Palat Center. And first, it's my honor to introduce the president of Cancer Hospital, Professor Jie He. First, we would like to invite him to give us an opening speech of this case forum discussion, please.
Okay. Hello, everyone. I am Jie He. It's my great pleasure to meet
On voit plus rien.
our experts and old friend from China and other countries online. As we know, esophageal cancer is the sixth leading cause of cancer-related deaths around the world. According to the report from the China National Cancer Registration Office in 2019, there were 0.25 million established nearly diagnosis esophageal cancer cases, and almost 2,100 cases died of the disease. The incidence and mortality rank 6th and 4th among all malignancies in China. Respectively, about 95% esophageal cancer are squamous cell carcinoma in China. The main risk factors for esophageal squamous cell carcinoma are excessive alcohol intake and smoking and bad life behaviors. Surgical treatment and surgical-based multidisciplinary treatment is still the most effective treatment for esophageal cancer. In China, chemotherapy combined with radiotherapy are currently the most common used preoperative neoadjuvant treatment for esophageal cancer. However, immune checkpoint blockade are being explored to treat lung and esophageal cancer. PD-L1 and PD-L2 are expressed in about the 44% of the esophageal cancer and are associated with the poor prognosis. Therefore, antibodies against the PD-1 has been used as a treatment for esophageal cancer in recent clinical trials. Many clinical trials are being conducted worldwide, but it is too early to make a definite conclusion on the therapy of the immune checkpoint blockade for esophageal cancer yet. Today, we will report 2 cases who had advanced esophageal cancers or has been treated with PD-1 antibody preoperatively, followed by MIE. Then we would like to invite participated experts to have a discussion on the 2 cases. Hopefully, this cloud forum will bring you a free treatment, new concept, and think on the efficiency and potential of immunotherapy for esophageal cancer. Thank you.
Thank you. Thanks. Next, we would like to start our discussion. And first, I would like to introduce Professor Ying Li. He would like to give us an introduction speech. The topic is preoperative PD-1 blockage combined with the new adjuvant chemotherapy for locally advanced esophageal cancer. Please, Professor Li. Okay.
Distinguished Professor Julie and Professor He, dear colleagues and friends, I would like to take this opportunity to say thank you for your participation in this Oeso platform on multimodality treatment for esophageal cancer. I'm privileged to introduce the first topic on neoadjuvant PD-1 blockade combined with chemotherapy plus surgery for locally advanced ESCC. Fine. The past decade saw a dramatic growth in the study on multimodality treatment for esophageal cancer, updated clinical guidelines, and modified from the high-level evidence trials. For example, NCCN guidelines recommend chemoradiation as an injection modality based on the results of CROSS and the clinical trial 5010. This is the long-term results of CROSS, the major OS of neoadjuvant chemoradiation therapy, and surgery alone group were 48.6 months versus 24 months respectively. In the ESCC subgroup, the median OS of two groups were 81.6 months versus 21.1 months respectively. Another clinical trial is 5010, and all the patients are enrolled as squamous cell carcinoma. The median of neoadjuvant chemoradiotherapy and surgery alone group were 100.1 months versus 66.5 months respectively. Well, we know GES guidelines recommend the neoadjuvant chemotherapy prior to chemoradiotherapy followed by surgery for stage 2 to stage 3 ESCC based on the result of the famous clinical trial JCOG 9907. Lessons from oncology-driven precision medicine cross clinical specialties. This is a little question. There is little questions that oncology has served as a vanguard for precision medicine in the advanced esophageal cancer. However, more measures are called for to boost the demand on the long-term survival, especially in the locally advanced esophageal cancer field. Combining immunotherapy and chemotherapy from multiple modalities intuitively appealing for improving surgical outcomes. In the ESMO 2020, the Keynote 590 study had proved the efficacy and the safety of the first-line immunotherapy plus chemotherapy for advanced esophageal cancer, especially for ESCC, ESCC patients with PD-L1 CPS more than 10. And similar to the Keynote 590 results, we found a satisfactory objective response rate and the disease control rate of multiple modality treatment for locally advanced and advanced ESCC. This is our prospective phase 1B trial on neoadjuvant immunotherapy compared with the targeted therapy and the chemotherapy. 30 locally advanced ESCC in total enrolled, and 8 cases completed esophagectomy. The most common 3 to 4 and 4 treatment related AE was neutral cytopenia. The objective response rate was 100% to date. No good quality randomized trials have prospectively evaluated the effect of combined neoadjuvant immunotherapy with chemotherapy for locally advanced ESCC. Therefore, our first phase 3 prospective multi-center open-labeled randomized controlled trial has launched recently. We are looking forward to answering these questions in the near future. Thank you for your attention.
Thank you, Professor Li. Next, we will start the case report first. We would like to invite Dr. Zheng Wang to report the case 1. The case 1 is a new adjuvant PD-1. Please.
Thank you.
Okay. Good afternoon, everyone. I'm Zheng Wang from Cancer Hospital. Now I will report a case received new adjuvant PD-1 blockade combined with chemotherapy plus surgery. This is a 63-year-old man had dysphagia for 2 months. The physical examination found no positive signs. The FGI endoscopy and biopsy show a tumor in the middle to lower esophagus. The pathological diagnosis is squamous cell carcinoma. The US and PET indicate that the tumor invaded esophageal adventitia, lymph nodes along the right recurrent laryngeal nerve and the node of paralower esophagus are suspicious of metastasis. No evidence of M1 disease was found, and the history is unremarkable. Here is a CT and the PET scan before new adjuvant therapy. We can see a tumor in the middle to lower esophagus. The standardized uptake value in PET is about 12, and the right recurrent laryngeal nerve, lymph node, and node parallel esophagus are all suspicious of metastasis. So the diagnosis is locally advanced ESCC, CT3 and positive M0, stage 3. Our first question is, which of the following neoadjuvant regimen is recommended? Preoperative chemoradiation or chemo plus immunotherapy?
Okay. Now we would like to start the panel discussion. So any professor, do you have any good suggestion or comments on this case? Please.
Yeah, Stefan Wönig from Geneva. So I think this is an enlarged tumor, and it is more than 10 centimeters in the length. For me, it's a very clear indication for a neoadjuvant radiochemotherapy. And so I would give a little bit more than the cross because of 41 gray is, in my opinion, not enough. We are giving now 50 gray for this case, and we know from the Mariette experience that there is no disadvantage for the surgery. And because of it's a very long tumor, there is a high risk after the neoadjuvant treatment of a stenosis, even if there is a complete response. And therefore, I would do neoadjuvant treatment with surgery after that. And because of the nodes along the recurrent nerve are involved, it has to be an Ivar-Lewis esophagectomy with a very high anastomosis and with lymph node dissection, 2-field plus extended with the nodes of the recurrent nerve. This would be my suggestion.
Thank you. Okay.
Yes. Thorsten Goetze from Germany. I agree with Professor Mönig. I think neoadjuvant radiochemotherapy should be the standard in this situation. And I think the underlying chemotherapy as backbone should be the same as in crossed carboplatin combined with paclitaxel, because it's less toxic than cisplatin 5-FU. And yes, it should be a discussion if 41 degrees are enough, or even 50 grays. I think 50 grays are better than 41 gray, but the step should be the cross protocol. Yeah.
Andrew Chang from Ann Arbor. I just wanted to offer a different opinion. I think I understand the rationale for the chemoradiation preoperatively. Whether 41 or 50, I think, is institution dependent. One question for Professor Mönig is, when you talk about the length of the tumor, are you considering that the tumor is extending up to the upper thoracic inlet because of that positive lymph node? Because the tumor itself seemed middle to lower esophagus. And so to base the decision, unless I missed something in the presentation.
So you are 25 centimeters for a person 1.80 meters. I think this is on the level of the vena azygos, and so the quality of life after Ivar-Lewis with a very high intrathoracic anastomosis is much better than a cervical anastomosis. This is our experience coming from the group of Siebert and Arno Völcher. And so if it is possible, I do an intrathoracic anastomosis with an extended lymph node dissection, but it's totally clear it's necessary to do a frozen section during the operation that you are really free. And if necessary, yes, we do a cervical anastomosis. But our experience with the cervical anastomosis is not so good. And we have an excellent experience with intrathoracic anastomosis with very, very low rate of anastomotic leakages. And you know, we are doing the hybrid technique, laparoscopy and thoracotomy. And we take a 28 secular stapler if possible, and then you have really rare a problem with stenosis or something. This is our approach.
Okay.
It's
Professor Junfeng Liu there. Hello, Professor Liu.
Oh yes, Dr. Liu. Yeah. Okay.
Please.
Yes.
You are the moderator.
Yes. Yes. According to the system, the moderator of this discussion of this session, and yes, I know. I would like to know whether Professor Wang will continue his report.
Okay. Thank you.
Yeah.
I will continue. Okay, according to the result of cross trial, neoadjuvant chemoradiation is recommended in the ACC guidelines, and according to the result from JCOG 9907, neoadjuvant chemotherapy is recommended in GES guidelines. This is the pattern of recurrence in the cross trial. We can see most common pattern of recurrence is hematogenous, even in the CRT group. So this indicated that current systematic treatment for locally advanced esophageal cancer may be insufficient. As we all know, immunotherapy has made great progress in the treatment of cancer recently. The result of Keynote 590 showed that chemotherapy plus immunotherapy could be the first line therapy for advanced esophageal cancer. Recently, more and more clinical trials focused on neoadjuvant immunotherapy RMV, and this is our trial. We use pembrolizumab, a PD-1 blockade, combined with chemo as neoadjuvant therapy for locally advanced ESCC. The patient participated in the clinical trial. And he received 4 cycles of neoadjuvant therapy, including pembrolizumab, nab-paclitaxel, nab-plantin. The treatment-related AE, including grade 3 leukopenia and grade 3 neutropenia. The CT and PET scan performed before surgery showed a noticeable shrinkage of the tumor and lymph nodes, and the SUV in PET also decreased significantly. So next, what's the next best therapy for this patient after effective neoadjuvant therapy? MIE or definitive chemoradiation or chemotherapy plus immunotherapy? Okay, Professor Liu.
That's a question, and after I'd like to know whether the any Chinese discussion is still online. Okay. Yes, great.
Okay. Maybe a small hint. We all know from adenocarcinoma in gastric cancer or in GA junction cancers that compared an indirect comparison with FLOT example given, that the systemic control rate of cross is not very good. So we need further therapies for these patients. Local control with radiotherapy and combining with chemoradiotherapy is very good, but the systemic disease is a great problem. And what is the perfect idea for this? Maybe we have a small answer seen at ESMO this year. We have seen the Checkmate 577 trial combining cross and after cross randomization to placebo or nivolumab. And the data are quite good, and maybe we have a new standard for these patients, especially in squamous cell cancer, combining this adjuvant approach of nivolumab. Yes. And I think it's even possible to integrate a checkpoint inhibitor in the neoadjuvant setting, because checkpoint inhibition is less toxic than other therapies, and the combination is very, very good.
I think this is a very interesting point, and we have some experience of immunotherapy from the palliative situation. But another aspect, and we are looking for that in Germany and in Switzerland now in randomized trials, is to combine cross with a more effective chemotherapy. And this is FLOT. We know that FLOT is very effective for the adenocarcinoma, and now we are doing this as an induction chemotherapy, 2 cycles before cross. And this could be help for limitation of the metastasis. This could be one aspect. But immunotherapy, I think this is a very, very interesting subject.
Just another idea. I think you have combined nab-paclitaxel, not so common in GI cancer besides pancreatic cancer, normally for breast cancer or lung cancer. But I think combining taxanes with platinum 5-FU is very promising for even for squamous cell cancer. So why not FLOT for squamous cell cancer? I think it's a promising approach.
Okay. Yes, I think although the operative adjuvant chemotherapy, radiotherapy, even immunotherapy can add some difficulties of esophagectomy, I think MIE is the best choice for this patient. And I have a question to ask Professor Wang Zhen. What's the right time for surgical interference after preoperative immunotherapy? 4 weeks, 3 weeks, or 6 weeks? 百科介入的最佳时间就是在清除免疫治疗以后，外科介入的最佳时间，几周合适呢？
What's your question, Professor Liu?
So what's the best time for surgical interference after preoperative immunotherapy? 就是外科介入的最佳的时间，就是什么几周是免疫治疗后几周做手术合适？
对 4 to 6 weeks after the new adjuvant therapy, maybe the best choice.
Okay, yeah.
Okay.
So,
okay, yeah, continue.
What's a good suggestion from Professor White? Professor White, you raise your hand.
Yeah, I was just going to make a few quick observations and questions. This is a long tumor, as was already described, 15 centimeters in length. One observation would be one of your options there, of course, was primary chemoradiation with or without immunotherapy. And I think a lot of this will depend on who sees this patient first. In many centers in the world, this patient would be seen first by an oncologist and a non-surgeon, and they would tell them this is a non-resectable tumor. And this patient would get primary chemoradiation. Even in my own practice, I have used 9 centimeters as a top limit for resection, and beyond that, telling patients that chemoradiation was probably their way to go. Now, bear in mind, I work in Africa where chemoradiation, simple chemoradiation, is very difficult for the vast majority of our patients to obtain financially and logistically. This patient, I'm interested to see the outcome as you proceed here, because this offers something to a patient who would heretofore, in my opinion, have been deemed non-operable with such a long tumor. And surely that tumor extends submucosally beyond what we're seeing, I would suspect. So if I were to operate on this person, getting back to the original point, I would put a cervical anastomosis. In our experience, I do primarily all McCowan esophagectomies with a high cervical anastomosis. In our experience, with about 1,000 patients, has been that they tolerate that very well. And so I would do that. But again, I bring up the point that I think many oncologists would never send this patient to a surgeon. And perhaps it's lucky in your situation that you get to see these patients earlier than many others do. Thank you.
Okay, is there any opinion from Professor Zhigang Li? Hello?
Okay. Yes, can you hear me?
Yeah.
Okay, so I think I totally agree with Dr. Wang, Jim Wang's opinion. Yeah, this is a very standard case of squamous cell esophageal cancer in China. So it's a lung tumor with lymph node metastasis and with induction therapy of the checkpoint, just PD-1. So we can see that the pathologic response is very good. So I totally believe in the future, the induction chemo and immunotherapy could be the standard for these kind of patients.
Thank you very much.
Professor Liu, continue.
Your case report, yeah, because time is limited. Continue your case report.
Okay, let's continue. Okay, the patient received MIE 4 weeks after completion of neoadjuvant therapy. He received oral feeding on the first post-operative day. No post-operative complications found. He discharged at 8 days after operation. The final pathological diagnosis is thoracic ESCC YPT3A0M0. However, it's not a PCR case. Yes, this is the pathology section of tumor and lymph node specimens. Here we can see the structure of submucosa and muscularis is disorder with fibrosis. The squamous epithelium is normal. And here we can find scattered tumor cells surrounded by the lymphocyte infiltration. And 2 lymph nodes, the right recurrent laryngeal node and the node paralower esophagus all showed complete response to the neoadjuvant therapy. The stage from clinical T3 positive to YPT3 and negative. At last, we still have some questions. Is it necessary to give additional adjuvant PD-1 blockade with chemotherapy for this patient to enhance PFS and OS? Could immunotherapy combined with chemotherapy be the potentially optimal neoadjuvant therapy for locally advanced esophageal cancer? Third, how do you evaluate the clinical response of esophageal cancer after neoadjuvant immunotherapy combined with chemotherapy or chemoradiation? Last, is surgical resection still necessary for the patients with clinically complete response after neoadjuvant therapy? And is active surveillance feasible for the patient with CCR? Okay, thank you.
Okay. Yes. Just please show your questions on screen. Show your all questions.
So my 4 questions?
Yes.
Okay.
Okay, Professor. Yeah. Morning.
Yeah. So for the questions for the PD-1 adjuvant, I think this is experimental. We have not the data that this is necessary. I think it could be a good option, but from the guidelines, there is no evidence that we have to do it. Regarding to neoadjuvant therapy for the patients with a resectable locally advanced esophageal cancer, so I would give chemoradiotherapy with FLOT. And could immunotherapy combined? Yes, but the data are not so clear at the moment. The evaluation of the response is very difficult. You know that we are doing in Switzerland with the group of Christopher Mariette a trial. The name is PRODRIGE ESOSTRAT trial. And we are looking for esophageal cancer after complete response. And we are randomized the patient in one arm with surgery and one arm with surveillance and the possibility to do surgery later if there is a recurrency. And it is always difficult to examine, to evaluate the response clearly. I've operated yesterday such a patient with a complete response, and at the end, there were clearly rest of the tumor, so it's difficult because of you need very deep biopsies. The PET scan is not 100% valid for this examination. So this is difficult for the moment. So this is my my suggestion.
Okay, Professor Gauss.
Yeah, maybe some additions. Maybe we have in the future, or shortly we have now seen the data from ESMO from the checkpoint 577 for the addition for PD-L1 blockade or for PD-1 blockade with nivolumab. So I think for squamous cell cancer we have the data, and probably there will be a new standard soon, adding first cross-send surgery, then adjuvant PD-1 blockade, quite similar to maybe the Pacific trial in lung cancer stage 3. We have a definitive chemoradiation and then PD-L1 blockade as maintenance of this. The combining, as Professor Mönig said, the chemo plus PD-1 blockade in the adjuvant setting, we have no data with this, and a quite interesting idea for a new trial. And the other thing is, no, I forgot my speech. Potentially, no, that's it. First one, yes.
Yeah, Professor White.
Yeah, I would add just briefly, agree with all that has been said. The final question, is surgical resection still necessary? I would say yes. This case demonstrates exactly why, because there's tumor remaining. I would only add the caveat that I would take into account the patient's age and comorbidities, so that if the patient's risk for surgery is increased significantly, then I might consider active surveillance. But the first choice would be surgical resection following neoadjuvant therapy.
Yeah, I would agree with Dr. White that first choice would be planned surgery after completing whatever neoadjuvant regimen was pursued. I'm just doing a quick search. I mean, we've been performing salvage esophagectomies, and the MD Anderson group also recently reported their experience with salvage esophagectomies in squamous cell cancer patients. And in that experienced group, they still had a very, a high morbidity rate, even a higher mortality rate. It's safe, but it's definitely more dangerous for patients. And especially if we are starting to think about possibly preoperative use of immunotherapy, several centers have reported that there's more inflammation, more adhesions after completing preoperative immunotherapy on top of what patients already receive. I'm looking forward to seeing the results from the Swiss-French trial that Professor Mönig talked about, because that's always the key question: is can you randomize someone to active surveillance versus upfront resection?
Any comments from Chinese colleagues? Professor Liu?
Yeah, yes, I think if even the complete PCR, yes, after neoadjuvant therapy, okay, I still suggest the surgery, yes, because there is several micro lesions in the tumor we cannot detect it. So, I suggest that surgery, even the PCR is achieved.
So I actually, for the last question, I have my comments. I don't think we have enough evidence to confirm that active surveillance can be used for the immunity induction therapy, because even for the cross trial, I mean, after induction chemoradiotherapy, we even haven't found the best way to find what is the CCR and what is the PCR. So for the immunotherapy, it's totally new induction method. So the pathologic response is totally different. So we need a long way to find a method to confirm what is the best evaluation method to confirm it's CCR. So I think active surveillance is not reliable now for the induction immunotherapy patient, is my opinion. Thank you.
So where is Professor Chen? Professor Chen, are you there? Okay. Shall we close this case 1 discussion? Professor Liu?
Okay, yes, yeah, the time is up. So, do you want to make a summary of this session? Mo?
Okay. So let's we start the case 2. First, I would like to make a short introduction. Use share the screen. The moderator will be Professor Zhentao Yu. Professor Yu? Hello?
Yes, I'm here.
Oh, okay. So,
am I clear?
Yeah, you just started case 2 discussion now.
Okay. Good evening, colleagues. For this part, we invite Dr. Leng Xuefeng have the case report, case 2. Please, Dr. Leng Xuefeng, are you ready?
No, there is introduction.
Oh, sorry. Sorry, please wait, Dr. Leng. And first of all, we have a short introduction speech by Dr. Mo Yousheng. He will talk about the immunochemotherapy, chemotherapy versus chemoradiotherapy, which is the potential optimal neoadjuvant chemotherapy for esophageal squamous cell carcinoma. Please, Dr. Mo.
Okay. So, immunotherapy combined with chemotherapy versus chemoradiotherapy, which is the potential optimal neoadjuvant therapy for locally advanced esophageal squamous cell carcinoma. So up to now, we don't know. So, about 80% of the diagnosed esophageal cancer patients are in the advanced stage. So neoadjuvant therapy combined with surgery is the standard care for the advanced esophageal cancer now. However, the 5-year survival is still unsatisfied, even though the patients received multimodality treatment. So currently, the neoadjuvant treatment modality included radiotherapy alone, chemotherapy alone, or both together, chemoradiotherapy. And nowadays, the immunotherapy is developing so fast. And we may give the patient the immunotherapy alone, or immunotherapy combined with chemotherapy, radiotherapy, or chemoradiotherapy. So table 1 just show you the randomized controlled trials of neoadjuvant chemotherapy plus surgery versus surgery alone. As we see in the table, the PCR rate is only about between the 2% to 13%. It's quite low. So the chemotherapy alone may be not enough. And table 2 just show us the randomized controlled trials of neoadjuvant chemoradiotherapy plus surgery versus surgery alone. the preoperative chemoradiotherapy can significantly improve the PCR rate of the squamous cell carcinoma. And the PCR rate reached 22% to 43%. The cross trial just demonstrated the preoperative neoadjuvant chemoradiotherapy can significantly improve the PCR rate for the squamous cell carcinoma and also the long-term survival of those kind of patients. And another important trials was conducted and finished in China, which was called the 5010 trials, and also demonstrated that a neoadjuvant chemotherapy can significantly improve the PCR rate and the long-term survival when compared with surgery alone. So our meta-analysis also demonstrated that neoadjuvant chemoradiotherapy can significantly improve the long-term survival. So currently, the chemoradiotherapy is the standard treatment for locally advanced esophageal squamous cell carcinoma. However, the immunotherapy is developing very fast in recent 2 years. And this table just shows us the very pilot trials conducted worldwide. And the primary conclusion is immunotherapy alone for locally advanced esophageal cancer is more safe, more effective, and has less adverse events and longer survival than the chemotherapy alone. So what these are the ongoing clinical trials of immunotherapy combined with the chemotherapy, radiotherapy, or even chemoradiotherapy worldwide. And also include the trials in China. And this table just show us the very primary clinical trials now are being studied, are being conducted in China. Just show you the 3 typical centers. The primary results showed that these 3 centers only enrolled a small group of patients with different stages, and they also use a different kind of PD-1 antibodies. And very primary results showed that even though the few cases studied, the chemotherapy combined with immunotherapy can achieve very similar results to the chemoradiotherapy. So currently, the neoadjuvant chemotherapy combined with VATS may be the best or optimal treatment modality for the locally advanced esophageal cancer. However, in the future, maybe the PD-1 combined with the chemotherapy or chemoradiation combined with VATS replaced this currently optimal treatment modality. So thank you very much.
Thank you, Dr. Mao, for your short instruction about the chemoradio plus immunotherapy before the surgery. And but unfortunately, I think you did not tell us the answer, which one is better, immuno plus chemo or the chemoradio for the neoadjuvant therapy for the esophageal cancer. I think next we would like to invite Dr. Leng to tell us the story of their groups. And Dr. Leng Xuefeng come from the Sichuan Tumor Hospital. Dr. Leng Xuefeng, are you online?
Yeah, I'm ready. Thank you,
Okay,
Professor Yu.
Please.
Good evening, our European friends, American friends, and also the friends, the colleagues from Africa. Good evening, Professor Mao, Professor Yu, and the colleagues from China. It's my opportunity to share a one of the case of our center. So I cannot share my screen. Can the moderator to check that?
Yes, you should be able to share your screen now.
Okay, okay, thank you very much. Thank you, greatly. Okay, here is the topic of our case. The MIE after neoadjuvant chemoradiotherapy followed by immunotherapy combined with chemotherapy for locally advanced ESCC. Also interested in this case with an unexpected outcome. So this is the case, a 17-year-old male. The gastrointestinal endoscopy showed the lesion located on the 27th to 31 centimeter from incisor. The pathology is squamous cell carcinoma. The CT scan showed it was a potentially resectable locally advanced middle thoracic ESCC. So based on the 8th edition of the AJC-CTM stage, it is the clinical T3N1M0 stage 3 patient. So this is image from the gastrointestinal endoscopy. We can saw the lesion located on the 24 centimeter and 27 centimeter from the incisor. This is the endoscopic ultrasonography, which showed it is located on the middle thoracic part. It is a T3 and positive tumor. The thickness of the tumor is 1.4 centimeter. Also, there's a CT we can see from the different levels of the thoracic. We can see it is at least a T3 tumor. So this is the first question. As neoadjuvant therapy for locally advanced esophageal cancer, what would you select or suggest for this patient? Thank you.
Okay, Dr. Long, thank you for your question. Now we would like to invite our colleagues to discuss about these questions. I think first of all, we would like to invite Dr. White. Are you there?
Yeah, just to give perhaps an international perspective to this, I work in sub-Saharan Africa, not in South Africa, where adjuvant and neoadjuvant therapy is unaffordable by most of our patients, so that neoadjuvant therapy itself costs more than the cost of entire surgical resection and hospitalization. So in our setting, I would offer this patient primary surgery with post-op adjuvant therapy. I understand that in the West, that is not the standard of care. And if I had the capability, I would offer neoadjuvant chemoradiation followed by surgery. But in our setting, that is not possible for most of our patients. And surgery is the primary tool we're able to use for them. This is clearly, I think, a resectable tumor. And so in my setting, I would go to upfront surgery, while understanding that in another setting, I would offer neoadjuvant chemoradiation. Thank you.
Okay, thank you, Dr. White. I think this is your standard. I don't think it's right or not right. So maybe in China, a lot of thoracic surgeons, maybe they choose the surgery first. So let's invite our Chinese colleagues. Dr. Qin Jianjun, are you there?
Yes, I'm here. I think for this patient, I think chemotherapy is adequate. Radiotherapy may be not necessary.
Just only chemotherapy.
Just chemo? Why? Why radio is not appropriate for this one?
I think this patient RD resection is adequate.
Okay. Okay.
Mr. Yang Hong.
Thank you, Professor Yu. I think that,
Okay.
according to NCCN guidelines, Cisco guideline, and ISMO guideline, I think for the patient with stage 3, potentially resectable, the standard choice, the therapy is neoadjuvant chemoradiation, followed by surgery. So in our center for this patient, we will also consider this standard therapy for the patient. But maybe there is one thing different, because the tumor we can see from the CT is close, is very close to the trachea and bronchia. So even the US evaluate that is T3, but for this kind of patient, we will routinely suggest the patient to receive the EBUS. I emphasize EBUS, not the bronchoscopy, because clinically we found that some patients, even under the bronchoscopy, the mucosa of the trachea and bronchia is normal. But sometimes when we perform the operation, we found that the tumor invade the trachea and bronchia. So nowadays, we think for this kind of issue, EBUS is obviously significant, obviously superior to bronchus, because the EBUS can found there may be potentially invade to the trachea. And if the EBUS diagnosed that the trachea has been invaded, maybe not wholly, maybe just part of the trachea have been invaded by the tumor, we don't think this patient is potentially resectable. We consider it's marginal resectable. And this is another topic. I think for marginal resectable patient, we will suggest neoadjuvant or induction chemoradiation for this kind of patients. Thank you.
Okay, thank you, Dr. Yang. You provide us a new choice for this case, and maybe later we'll talk about the which one is better, the EUS or the EBUS. Okay, I would like to invite our German colleagues, Dr. Gut.
Yeah, so I would suggest in these cases clearly a neoadjuvant treatment with radiochemotherapy. I would give 50 gray in this situation. For all squamous cell carcinoma, we do a bronchoscopy in every case because we have to look if there is an infiltration of the bronch, and we have to look to second tumors because of these patients have the risk of second tumors of the lung. And we would do a scanner with very thin yeah, and then probably you can see if there is an infiltration or not. And I would do 2 weeks after end of the radiochemotherapy, the images. And if there is clinically a good response and a good response examined by the images, I would wait a little bit longer and I would do the operation 6 to 8, 9 weeks after end of the radiochemotherapy. And we have some good data coming from the rectal cancer that it's better to wait. And now we have the same data from the esophageal. If there is no response, I will do quickly the operation, probably.
Yeah. So, as just Stefan Münich said, this is the right way. I think if you have no option to perform neoadjuvant chemoradiation, the direct surgery may be an option, but to perform direct chemotherapy or adjuvant chemotherapy, we have no real data for squamous cell cancer in this setting. So if I perform a neoadjuvant therapy, I'd like to perform chemoradiation because we have a very good surrogate marker and it's the complete path response. And the complete path response in CROSS is nearly 50% for these tumors. And so it's definitely the combination of chemo and radiation for these patients for optimizing the therapy. Yes.
Okay. Okay. Thank you, Dr. Bonnet. I agree with you. And Dr. Chen Chun, are you there? Dr. Han? And Dr. Li Zhigang, would you like to say something?
Okay, this is T3N1 squamous cell esophageal cancer. So I just like induction chemoradiotherapy. It's reasonable and safe. It's my favorite. Thank you.
Okay, thank you. Thank you for all the colleagues. And Dr. Long, would you like to continue, please?
Okay, I will continue.
Okay, thank you.
So thank you very much for all the colleagues for these comments. So we're going on. So based on the NCCN guidelines, we know for this kind of patients, the preoperative chemoradiotherapy may be the best choice or the most evidence-based choice. So we choose the neoadjuvant chemoradiotherapy for this patient. The chemotherapy we used 2 cycles, paclitaxel and the carboplatin. The radiotherapy we used the IMRT, a total dose of 40 gray. The patient was administered in 20 fractions. Each fractions were 2 gray and 5 fractions per week. So after the treatment, we can say the date, that is in August last year, the gastrointestinal endoscopy showed the on the 24 centimeter and 27 centimeter from the incisor, we can say the tumor is still there. Unfortunately, the EOS showed the middle thoracic lesion progressed to T4A. The thickness from 1.4 to 1.8 centimeters. So we also can say the CT scan, it showed in the level of carina, we can say the tumor increased, and also in the level of inferior pulmonary vein level, the tumor also progressed. So the next question, if this patient has a poor response to the chemoradiotherapy, what regimen or what kind of strategy would you suggest for this patient's next treatment? Thank you.
Okay, thank you, doctor. That's interesting. So it's a not good case for preoperative chemoradio. So I would like to invite our colleagues from Switzerland, Dr. Monica, are there? Do you have some comments or some suggestions about the strategy?
So this is a very difficult question because we have no good evidence what is to do. So I would go for surgery. If I would think it's resectable, I would go for surgery. You can try to do a more radical chemotherapy, but it's a local problem. And I think if the radiotherapy is not working for this tumor, it's the probability that chemotherapy is shrinking the tumor is not so high.
So your opinion is to surgery?
Yes,
right?
I think so.
But from the CT scan, maybe it's a tough work for a surgeon to do the operation.
Yeah, but you know, if there is an infiltration, you cannot do surgery. But if there is no infiltration, I think you will bring it out. And even if there is a response of the tumor, it is not an easy operation.
Okay.
Because of then you have the necrosis and all these things, and sometimes even if you have a complete response in the PET scan, it's a very difficult operation. I had yesterday this, it was a complete response, and it was really tough.
Yeah, sometimes it is. Thank you. I would like invite Dr. Chang. Andrew?
Actually, a question for Professor Monig. So in the last case, you had talked about preference for an Ivor-Lewis approach, meaning that you would have to start in the abdomen. In a case like this, would you start in the chest to evaluate the airway first, but still then plan for an intrathoracic anastomosis? So you chest, belly, chest, or would you even go for a cervical anastomosis and basically a McEwen approach where you do chest first and then abdomen next with the patient supine? My preference would be to start in the chest to explore the airway and see whether it's resectable. But as you probably know, our preference is also for cervical anastomosis. So this is within our usual sequence.
So if the resectability is not clear, I would always start with thoracic approach because of, and I think this case, for me, I would do it open. For this T4 cases, I would do an open approach, and I would start with thoracotomy, and then you have to see if it's necessary. McNone, it's very clear, but if you can have anastomosis high in the thorax, 20 centimeters, I would do it.
Okay, but if you cannot move all the tumor clearly, do you think the chemo is still effective after surgery?
So if you do one resection, or what?
I mean, after surgery, you cannot move all the tumors clearly. So you need some extra treatment for these patients. You prefer radio? You have 50 grade radiotherapy, but for chemo, it's not effective.
So if you do surgery and you cannot resect the tumor as zero, it's very difficult. And if you have some rest of the tumor on the level of the bronch or the trachea, and you do additional radiotherapy, you will have a problem after that, I think. So this is difficult. And chemotherapy, is probably for a local problem not the best. This is a situation very, very bad. It's palliative, I think. The only good thing is that the patient can swallow after this. He can eat, but it's a palliative situation for me.
Okay. Okay, thank you. Is Dr. Chen Chun here? Dr. Xu Shun? No? Okay. I would like Dr. Qin. Do you have some comments?
If I meet the patient, I'll judge the resectable timely surgery. If unresectable, I recommend chemotherapy plus PD-1.
Plus PD-1, but for this case, it seems that it's unresectable from the CT scan. What's your choice next?
Chemotherapy plus PD-1.
Maybe plus chemo, okay? Chemo plus immuno, right?
I think unresectable.
Okay, yes, I think it's unresectable. Do you want to say something?
Okay, thank you. I think this patient received the standard NCCN guideline recommendation treatment, induction chemoradiotherapy, but unfortunately the tumor progressed during the treatment period. So I think this reflects two problems. So first, I think the cross treatment maybe not so effective for large tumor in Asia. So someone ever reported, and just like Hong Kong, Dr. Low, he has a paper talking about this problem. So second one, so maybe we need increase the evaluation frequency to increase the chance to timely surgical intervention. That means maybe we cannot waiting 4 weeks, 8 weeks, maybe in the middle of the induction therapy, we make another evaluation so we can timely make the surgery intervention. So I think this is possible future work for the treatment. So for me, for the subsequent treatment, so actually I think I like selected the safe and reasonable treatment. I think I like the second line, just medicine treatment. Maybe we can use the PD-1. Maybe we can change to another, just 3 drugs treatment, just like Japan, to confirm the tumor's sensitivity. So if we select the surgery, so there's 2 possibilities. So one is just artery resection, this tumor residual. So usually there's a infection of the thoracic cavity, postoperative. So idea. If we can select combined organ resection, just like aortic resection with the aortic homograft replacement. But I think for this position, I mean, in the middle, just near the coronal is not a good idea. So for me, I like the very safe, just second line physician medicine treatment. Thank you.
Okay, thank you, Zhigang. I agree with you. Maybe DCF is maybe a little bit more effective than the pre-chemoradial. Okay, thank you all the colleagues for your comments. Dr. Leng.
Okay, I will.
Okay.
So this is what we're worried about. So the surgery. If we perform the surgery, there is a high risk for the R2 residue of the tumor. So in the year of 2019, we know the immunotherapy is a hot topic. Also for the advanced cases of esophageal cancer. So also based on the NCCN guidelines, we know the second line therapy for these kind of patients or the very advanced or metastatic cases, we can try to use the pembrolizumab or some kind of anti-PD-1 drugs to treat these patients. So we finally to choose the immunotherapy. The immunotherapy, we used the chemotherapy to combine the immunotherapy drug. So we used the 2 cycles of albumin-bound paclitaxel and the cisplatin. For the immunotherapy drug, we use a domestic company from China. The drug's name is sintilimab. So after the 2 cycles of treatment, we can see from the gastrointestinal endoscopy to this 2 cycles of treatment, the membrane of the esophagus seems cured, I think. So, but the ES also showed that there is a residue of the tumor, but the T stage downstage from T4A to T3, and the thickness of the tumor also downstage from 1.8 centimeters to 0.74 centimeters. So this is a CT scan. We can see different period of the treatment. The first from the left to the right, we can see the first time, the second time, and the last time of treatment. Also, the tumor shrinked obviously. So the question is, how could you perform surgery after a long and a complex neoadjuvant therapy? You know, based on the chemoradiotherapy and then chemotherapy combined immunotherapy. This is also a risk for the patient when the patient performs the surgery, I think, even it is IMIE. So do you think the surgery is still necessary or not for this patient? Professor Yu.
Okay, thank you, Dr. Leng. I think it's a magic result for these patients. And I would like Dr. Bonnet. Dr. Bonnet, over there.
So I think it's necessary to do surgery. And I will start with thoracic approach. I would do it open. And my question is later, the situation on the bifurcation? Was it easy to bring it out, or was there a contact with the bronch? But this is a question to the surgeon who has done it later. I would do surgery.
Okay, Dr. Long, keep the question. Okay, about Dr. Chang, Andrew, you have some comments about this?
Yeah, but I think Dr. Getz and Dr. Young also had questions. I don't know if I've already spoken, so I'd like to hear what they had to think about this. I do want to point out that had we taken Dr. White's approach, the tumor would be out already, and then we wouldn't be worrying about the progression of disease, but that's a totally different discussion. But I do want to hear what Dr. Getz and Dr. Young have to think of on this.
Yeah, yes,
Okay.
thank you. I think, as Stefan Münig said, surgery is still the standard and the only way for a curative situation for the patient. All other options are experimental. And if you have a one or a two resection or a plus a resection, I think the NCCN recommend a boost in this area with a radiotherapy. And I would preserve immunotherapy for the palliative situation still, or as in Checkmate for the adjuvant situation, but normally I would preserve a substance sparing for further concepts in the future. And if the patients will develop a relapse. So it's an interesting case, but it's not so normal.
No, yeah, I agree. It's not normal. It's not so normal. Please, Dr. Zhigang, you have some comments?
Surgery. Yeah, I just like surgery because there's a lot of evidence that confirm even there's a clinical the complete response, surgery is good for the future survival. So I like surgery.
Okay. Okay. And also there's another part for this question is about the interval between the end of the chemoimmuno between the surgery, the time period.
Okay, usually because we have more than 50 cases experience for the induction chemo and immunotherapy. So usually we like the 4 weeks after induction. So I think 4 weeks is okay.
4 weeks. You think 4 weeks is optimal, right?
Yes, interval.
Okay, thank you.
Yang Hong.
Any comments from our colleagues?
It's okay.
Yeah.
Okay. I would like to share. Thank you, Professor Yu. I would like to share the data from the NUTAP-5010 trial. I just made a quick review of our trial. The data that this kind of situation is really a rare issue because in NUTAP-5010 trial, 224 patients, 224 patients received neoadjuvant chemoradiotherapy, and in that group, 4 cases experienced disease progression before the surgery, and 1 case is experienced PT before the CRT. So this kind of situation is really rare, and I would like to emphasize that sometimes after CRT, it's difficult to evaluate using the EUS. Especially we noticed that some patient radiology may have progressed, but indeed it's caused by the soft tissue edema, like the esophageal wall or the adjacent soft tissue around the esophageal. So for that kind of patient, because the EUS confirmed that it's T4A, so in our center we will continue to perform the surgery. But of course, after the immunotherapy, I think it's better. So in that situation, we will perform surgery. Thank you.
Thank you, Dr. Yang, for your interesting comments about this case. Time is up. I think maybe Dr. Morg. Do you have some comments?
I would only to say that for the radiochemotherapy, we have very good data that you can wait 6, 7, 8 weeks. But for the chemotherapy, we have not this data. We have the data from the FLOT trial, from the MAGIC trial, from gastric and junction cancer, and we know that normally you wait 4 weeks. But if it is possible to wait longer, we have not the data, and the same for the immunotherapy. So 4 weeks, I think it's a good time to wait, and normally then the patients are fit for surgery.
Okay, thank you. It seems that most of the thoracic surgeons want the time interval is 4 weeks. Okay, thank you. Dr. Long, please continue.
Okay.
Okay, thank you.
So at the beginning, we also lacked the confidence because we have no experience of this kind of patients who, after this kind of therapy and then perform surgery. And also there is no evidence-based trials or anything to show that how to do. But we decided to do surgery. And we performed the minimally invasive esophagectomy and they styled MyQ1. So there's a short video we can see. So this is the upper mediastinal part. We can say after the chemoradiotherapy and the immunotherapy, we also can see the it is a relatively clear anastomosis, the anatomy space, I think. So this is the recurrent laryngeal nerve lymph node dissection. We can see the coronal part, inferior pulmonary vein parts, and the lower part of the mediastinal. We think this is a totally R0 resection. This is some part of a video from the abdominal part. So it's very lucky for this patient. We performed the R0 resection, and the patient seemed recovered very well after the surgery. This is the X-ray from the patient post-operative day 2. We can see it seems relatively normal. And the laboratory test also was normal for this patient. And the pathology after surgery, we can say the patient is a YP, T1B, N0, M0. It is a stage 1 patient after the neoadjuvant therapy. But unfortunately, on the day 4 of this patient post-operative, in the morning, 5 a.m., there was a sudden stop of heartbeat and breath for this patient. We don't know why, but after the rescue of this patient, we cannot save this patient's life, and also the patient's family refused to autopsy of this patient. So it's very sad for that. Okay, the question is, what would you consider the reason for this sudden death of this patient and how to prevent it? Thank you.
Thank you, Dr. Long. But honestly, I don't like these results as a thoracic surgeon. And our colleagues, do you have some comments about this, the reason why this sudden death for these patients? Okay, Dr. Monica.
So I think there is not a surgical problem. I think if you have this very extended neoadjuvant treatment with radiochemotherapy, with additional chemotherapy, plus immunotherapy, you have a very high risk of lung embolism. You see it if you compare patients without neoadjuvant treatment and patients with neoadjuvant treatment, and you have a higher rate of embolism. Probably this could be a good explication for the death of this patient, and probably we need anticoagulation a little bit more if we are doing this extended neoadjuvant treatment.
Yeah, thank you. Zhigang?
You muted.
Yeah. 我开了声音了。 Okay. Zhigang, maybe Dr. Zhang, Angel,
Yeah,
you have some
Zhigang,
comments?
you're muted.
Okay, yeah, you.
Okay, I think Zhigang was trying to say something, but so I agree with Dr. Moenring that PE is a likely cause. I noticed that, and you mentioned this as a cervical anastomosis, there was a nasogastric tube in place. I worry about aspiration as another possible event. How long was the nasogastric tube in place after the operation? Had it been removed post-operative day 3 or day 4? And so is it possible, and as Professor Moenring pointed out, there are higher risks for the cervical anastomosis, especially because of the recurrent laryngeal nerve being so closely dissected. Was the patient hoarse after the operation?
Okay, thank you. Dr. Bonnet, do you have some comments? Dr. White?
So I think aspiration is a big problem after esophagectomy in all the cases, but the patient died not so quickly. You know, they have an aspiration, probably they have to be intubated, but this is, I think it's a problem. It's a lung embolie or it's a heart problem, but important is that we have to think about this. I had in the last 3 years, 2-3 patients with problems of lung embolism after neoadjuvant treatment. And so I'm a little bit more aggressive with anticoagulation directly after the operation. I start with liquimine 10,000 and then have a look 2 days later, PTT 50 is possible. And so this could be a possibility to prevent these things if you have really an extended radio, chemo, immuno for.
Okay, thank you. Dr. White, I see you.
Yeah, I would agree that pulmonary embolus is probably the most likely cause. I would give all these patients on the table anticoagulation. I think that the deep venous thrombosis likely forms during the time of surgery. And I give them preoperative on the table Lovenox or low molecular weight heparin, or even unfractionated heparin if that's all that's available. I would just return briefly to the previous questions. I would have operated on this patient for sure. I would begin in the chest as has been described. I think it's a good learning point for some of the younger surgeons who might be listening that the left main bronchus is a frequent source of problem. It's somewhat difficult to access from the right chest. And as was shown on the CT, this tumor is very close to the left main bronchus. So that is the place I would go to immediately. And I would have a discussion with the patient beforehand that this is possibly unresectable if we go back to before the immunotherapy, and let them know that this was their chance of cure. But if I found an unresectable situation, and I think CTs can be fooling. There are times you look at a CT and think it's not resectable and find out it actually is. But if it were not resectable at the time of surgery, I would place an endoscopic stent for that patient for appropriate palliation post-operatively in that patient. But I agree that to answer your question, that pulmonary embolus was probably the cause, and I would be more aggressive in pre-op and intraoperative anticoagulation. Thank you.
Okay, thank you. Our German colleague. Sorry.
Yes, one question. How long was the pure operating time?
Yeah, Dr. Lang, how long is the operating time?
Operating time nearly 5 hours for this patient.
Oh, all right. Okay, it's fine. Okay. Yeah, I don't think that's that the problem will be caused due to the perioperative or neoadjuvant treatment, because we do a lot of neoadjuvant treatments. But I think you have done all the measurements before hepatic values and something like that. No signs of pneumonitis or so. I think And this isn't the cause of the problem. Yeah.
Okay.
That's my opinion.
Okay. Thank you for your opinion. Dr. Qin Jianjun. Dr. Qin.
I think we don't know exact reason, but from last year to this year, several published trials tell us chemoradiotherapy plus PD-1 is a high risk procedure. So the radiotherapy and PD-1 is very dangerous.
Okay, so maybe you mean that the immunotherapy, the side effect of the immunotherapy may be the cause of the death of these patients.
Yes.
Okay. Okay, thank you. Is there any comments from our colleagues online? Dr. Mao, please.
Dr. Lang, do you use any anticoagulation treatment for the patients post-operatively?
Okay, Professor Mao, I'm very sorry we do not use that because it's very rare to happen, I think, for esophageal cancer patients after surgery, especially for Asian patients to have the VTE. We also consider the VTE at the beginning, but the patient has walked on the ward just 1 day or 2 days post-operative. So we don't think this is probably caused by the venous thrombosis, yeah.
I quite agree with the Professor White and the morning. And I think the primary embolism is the first cause of this patient standard days.
Yeah.
So the one reason is longer operation time, 5 hours. And the second reason is the patient have a lot of new advent therapy. And the third reason, you didn't use any anticoagulation treatment post-operative. So I have a very sad experience. I have a patient who underwent pneumonectomy. On the first day, the patient go around the ward, and the patient then go back to the bed. And about 1 hour later, the patient had a standard days. And only in 5 seconds, we didn't respond to that. We cannot do anything for the patient. So that is very dangerous.
Okay, that's pity.
I think we have an additional comment and question from Reda.
Yes, maybe this is my first time to this. I am the Professor Dr. Reda from Egypt. My first sharing, and I am very happy to be one of this big professor. Going back to the second or third questions, because I tried to raise my hand, but maybe it is too late. I proceed to surgery after this long trip of neoadjuvant, and I agree with Professor White that I have to start with chest, and I do it open. And back to this question, I think the pattern of death of this patient, the sudden, it is mostly due to pulmonary embolism, and I think with this patient we have to start early prophylaxis against pulmonary means, and maybe if this patient start early, this prophylaxis could save his life. Thank you.
Oh, thank you for your good comments. And sorry, I cannot see all our colleagues on the screen, so maybe I did not see that you raise your hand. And is there any comments? Maybe you can just say something online, our colleagues. Any comments?
Professor Ni?
No?
No comments. Thank you.
Yeah. No comment.
Okay, no comments. So maybe Dr. Long, you can close your case.
Okay, thank you, Professor Yu. In fact, do you consider the cause of the, it's the immune therapy? Do you consider the toxicities from the autoimmune, from the carditis, a sudden death from the problem of heart? So this is also one of the reasons, I think. Okay. I finished my presentation about the case. So, Professor Yu.
Okay. Thank you for your interesting and a little bit tough case. And maybe we would like to invite Dr. Mao to have a small summary for this case too. Dr. Mao?
Okay, thank you very much. And thanks to every distinguished professors and to participate this crowd forum on the multimodality treatment for locally advanced esophageal cancer. We reported 2 interesting cases, and we have a very detailed discussion on all the treatment procedures. So even though the COVID-19 virus pneumonia prevent us to meet personally, but we can meet the online. So we can also have a very good chance to meet online and to discuss our interesting cases. So thank you very much. And we cherish this chance, and we still hope we have a chance in the future to meet everybody and to discuss more interesting cases. Thank you very much.
Robert, do you want to conclude for the last word?
Yes, of course. A few words to say that it was a fantastic confrontation of ideas with a great level of discussions, even though we had a great number of surgeons in the debate. And indeed, we had discussions on topics such as, well, perioperative immunotherapy with monoclonal antibodies and the need for complete pathologic response. We saw the importance of microsatellite and stability and biomarker for efficacy of immune checkpoint inhibitors. This was of great interest. We had a discussion on neoadjuvant therapy with and without X-ray therapy, with reference to the CROSS trial, with the FLOT trial, showing the need of randomized studies, I think, on compared efficacy of protocols to define the best predictive factor for recurrence-free survival. We even heard about new techniques of radiotherapy in one of the presentations on intensity modulation radiotherapy, which was very interesting. We had comment of the pathology score for tumor regression when currently there is no molecular analysis. And quite simply, I think we understand that it is still rather impossible to objectivate 100% complete response. But what I think is when it unites persons of such a caliber as all those who took part today, such exchanges on these 2 well-chosen cases representing our profession an unequaled educational tool and a true vehicle to go further in our specialization. And the value of this discussion is so important that we already spoke with Professor Munich that they will probably be part of the scientific program of our 2021 Congress. In a way, Oeso expresses its appreciation to all those from so far away in Asia, in the US, from Africa, from Europe, with that so willingly share the part of their vast experience to lend special value to this virtual encounter. And again, thank yous in plural must be also sent to Frederick Julie, the president of the Oeso Foundation in Geneva, who watched over who watched over the preparation of this event. Once again, it was carried out in a most professional way, in spite of the many details he had to take care of today, especially in view of the linguistic difficulty it presented. And at the same time, I thank Dr. Jagan Lee, a member of the panel as well, who was constantly on the phone with me and with Frederick to make communications easy in the 5 parts of the world. And of now, before leaving, I would like to once again say to Professor Ji Ho, who had the formidable task of organizing from China this session with so many participants, not to mention the participation of the impressive virtual panel. I would like to say to him and to Professor Mao as well, to have moderated such a high-level debate, which will remain as a reference for all those involved in the esophagus. Professor Stefan Monique, who is so actively participating today, is already preparing the discussion to come next, and this will be in December this year, before the first one in 2021, that will be transmitted from Melbourne, Australia, with Professor Matthew Reed. And the 5 new pilot centers in China that join that of Beijing today, will they too actively contribute to the projects of the Oeso Center platform. In the very, very near future, the days to come, I hope, they will join the next exciting stage of our course, the gastroenterology portal, which will become a benchmark for multidisciplinary expertise in esophagus. And to bridge the future with ancient Chinese mythology, I offer you the kind face of Huang Ti, the organizer of medicine. Thank you so much for your participation.
Thank you, everyone. Bye-bye.
Bye-bye. Thank you very much.
Thank you. Thank you very much. Thank you very much, everybody. Fernando from Argentina.
Au revoir. Auf Wiedersehen.
How are you? Thank
Bye-bye.
you. Thank you, Professor Goulis. Thank you. Bye-bye.
Thank you, Dr. Mao, for your contribution and what you did for the organization of this beautiful session. Everyone is very grateful to you and to Professor Jeho.
Thank you.
Thanks,
Thank you
everyone.
again.
Good night.
Thank
Good
you.
night.
Bye.